think we should move on to the next session. Otherwise, we'll make the same mistake what the previous session did. Thank you
Once
so much,
again, sir,
Guru.
thank you. Thank you.
Thank you so much. Fantastic. Let's move on with Alexandra. Let's see what she brings interesting to us.
Well, thank you first and foremost for having me. It's such a pleasure to be with you today. And the title is A Humbling Speck of Dust. So this is a 37-year-old gentleman who came in with corneal laceration, white cataract, intraocular foreign body, in his left eye. He had no evidence of endophthalmitis, even though this was 2-day delayed presentation. He was lucky that way. Count fingers vision, and the history is he was using the air hammer 2 days prior. He is a mechanic, and that's what he does all the time, no eye protection. So he underwent a pretty standard surgery, partial vitrectomy, lensectomy, given the white cataract and violated capsule. We removed his intraocular foreign body, did some laser at the impact site. He had vancomycin ceftazidime, and I routinely do it if I have IFB and fluid air exchange. The patient did really well, and he has this cross on his Optos photo from his corneal laceration and sutures. So he was indeed blessed because he did extremely well. 3.5 months later, he is aphakic, so we decide to implant a secondary IOL. We do 4-point scleral fixated IOL with cortex suture, and the patient regains actually 20/20 vision. So of course, we are celebrating and thinking that we're doing really well. And this is 6 months after the secondary IOL implantation. So now that's 9 months after his initial surgery. He develops a conjunctival erosion over the temporal cortex suture. So he has one temporally and one nasally. And we take him to surgery. When we explore, it looks like the suture is somewhat loose. It just doesn't lie flat on the sclera. The knot, though, is buried. There's no exposure of the knot. So he had the scleral reinforcing graft placed and conjunctiva is closed. He is doing well again. And this is 1 month after that graft. And 1 year, so we're a year out after his secondary IOL, he develops another erosion. And at this point, the patient's vision is 20/20. His eye is wide and quiet. We do some cultures in the clinic, nothing grows, and we decide to take him to surgery. And we are once again operating under the assumption that somehow that suture, is a little loose and it just keeps moving and causes conjunctival erosion. So this is the surgery that we're in, and we're checking that suture. And Jay, maybe I can ask you, what are your thoughts at this point? This guy has eroded now twice. I think you're
Sorry,
muted. There we go.
yeah, sorry, yeah. So I know that this is a tough situation, and now I'm just thinking that it's been such a long time I put sutures. So yeah, this was the benefit of moving for all of us to moving to Yamane, but the erosion is still common. I would still just go ahead and try to put a graft because his vision is good, the lens is doing well. So this is what I would just go ahead and put a graft. Does he have any scleral thinning or collagen disease? Because we have had surprises where the minute you make a sclerotomy, it just opens up. Did you investigate him?
Yeah, nothing like that. He is a mechanic. He says that he continues to work in his shop. He's worried maybe he's touching or rubbing the eye, but nothing excessive. Yeah, the suture did look like it's a little loose. Before I move forward, anybody else would do anything different at this point? All right, so we decided we used actually sutures to kind of secure that Gore-Tex because we thought maybe it was from continuous rubbing, and then we did the Tutoplast to cover it. The case went well, and we also decided to culture the suture. It was cultured in the clinic, but now we had a nice, kind of cleaned up suture that we cultured. And the patient post-operatively, even immediately after the surgery, is doing great. He's always had good vision. This didn't bother him or hurt, had any pain. And this is what the culture comes back. So he grew this pigmented mold called curvularia, which is, I don't know if you guys see a lot of it. We don't see a lot of it in Ohio. When we look back at his surgery, you know, the area, there was a pigmented area, and we thought that's the area we cultured, but we weren't very suspicious because the guy is a mechanic, and we thought maybe it's like some speck of dust on this suture. So he has actually, looking carefully, he had 2 skip lesions that were with this presumed curvularia at this point, and it's pigmented, and that's why it's so black. So the question now is, you have this gentleman, no vitritis, no AC cell, 20/20 vision. He is post-vitrectomy, and he has this these 2 lesions. So maybe Kouros, I can ask you, what would you do at this point? The guy's like, I have no problem.
It's a tough situation. I don't know much about this fungus, but I guess you have 2 options. Either just watch it closely. That's probably what I would do. And I can give you another example of this with a different bug, but watch it closely. And if at any point it starts getting worse, then you need to operate and remove the lens and the suture and treat it with antifungal. But probably at this stage, if everything looks good and nothing is going on, I may just monitor it closely. But again, what did you do?
Dr. Shanmugam has a comment. Let's see what he says. You are muted, sir.
Can possibly try subconjunctival antifungal as well as intravitreal antifungal. So that may work, and repeated subconjunctival antifungal over the suture, near the suture, may work as well. I have tried this in buccal infections.
All right, I don't think I'm trying to see if anybody else has comments. Well, you guys are all much more brave than I am. We were worried that this was actually the reason why he kept eroding, you know, multiple times. And I've seen some curvularia when I was in Miami, and it was bad. It was usually it's like patients who have severe inflammation, severe infection, and you know, I think we even lost eyes to curvularia. So we decided that we're going to take everything out. So we actually were careful. And the other reason why I wanted to do it is because one of those skip lesions actually was going into the sclerotomy. You know, it's basically communicated with his vitreous. And I think what happened is he just had a very small areas of infection, and probably because he was vitrectomized, you know, we didn't get as much of endophthalmitis really. And we removed the suture, and we made sure we didn't track it into the eye, you know, the way we cut it. So it was all external. We actually looked, and there was in the area of pars plana, really, there was this pigmented spot that we lasered. And who knows if it was anything, but we did treat it. And we injected antifungals and put patient on the oral antifungals. Go ahead, please.
Aleksandra.
Yes.
Gopal, you are not muted. If you want, yeah, yeah, he's good. Go ahead, please, Aleksandra.
Okay, excellent. So we treated that area, and all the cultures were negative. We took the vitreous, we took the lens, we took pieces of the suture, everything was negative. And there's been about a year since we removed everything. The patient is 20/20 still with a contact lens. And we've discussed, you know, if he wanted to do anything, and he was very happy. The question is, we don't know where it came from. Like I said, it's not something we see in Ohio, and could have been with initial trauma, but that was so delayed, or something that he, you know, rubbed somehow. So that remains a mystery. I mean, it's a good outcome, but kind of a challenging situation. And I never had to tell a patient who's perfectly happy with a 20/20 vision that I'm going to take out his lens. But I think in the end, it was the right decision for this situation.
I want to make a quick comment. Great presentation, Aleksandra. You know, I had a similar case with a P. acne. Patient had a cataract surgery, had YAG done, detached, I fixed the detachment. He's 20/20, but he has this low-grade inflammation that we cannot get rid of, like trace of cells, doesn't go away. We do an AC tap. They do a PCR. It's P. acne. The patient is 20/20 asymptomatic with this trace of cells. So we decided just to give him, we do so much injections. I was giving him monthly Vanco injections. Vanco is very safe. So we give him like every 2 months a Vanco injection. And suddenly I get a call on a Friday that he presents with a hypopion and everything. And we ended up needing to treat everything. He did great afterwards, still was 20/20, but that shows you that you probably did the right thing. At some point, probably the whole thing needed to be removed.
Very interesting. Dr. Murthy, any comments? Dr. Hemant?
I think that's one way of looking at it, because we do come across patients with P. acne or low-grade endophthalmitis with good vision, and then they deteriorate whenever you stop the steroids, and we end up removing these lenses because then they have a long course. Only after removal do they quieten down. So I think that's a good move.
Yeah, they usually come back on a Friday afternoon. So
There was a Monday surgery, so much more controlled.
So Alexandra, I have a question for you. Now, when the patient is 1 year down the road, 2020, would you put the lens back in?
So we discussed it with him, because I don't think there's any ongoing infection, and I think the infection was of the suture, because I really don't think it was the lens itself. He's debating it. He's enjoying a good vision with his contact lens and very happy. So he's trying to kind of decide what he wants to do. But I don't think it's unreasonable if he's off the steroids, he's off his antifungals, to consider it. I don't think there's any indolent infection that's hiding. To the point that was made, I feel like if he was still on steroids and then you stop and there's a little cell, I would be a little concerned.
Good. Any other comments?
I just want to make one small comment of an experience of one guy whom I found out that there was a calasion or hordeolum internum while I was doing the vitrectomy. And this guy developed an endophthalmitis. And so I had to do a revitrectomy. So during the surgery, just when I cleaned and draped, I saw this hordeolum internum spurting out. That was a very bad experience.
So Gopal, that should have been postponed then immediately at that time only.
Probably, yeah. Retrospectively, yes, sir, definitely, sir.
And Alexandria, wonderful presentation. Where you see, I would have put this patient on antifungals for a couple of weeks, oral antifungals, which are pretty effective, or maybe intravitreal and intracameral also. Because you see, intervening in a 20/20 eye, patient consent is not so easy to get.
But I think Alexandra wanted to sleep peacefully. So,
Kouros likes operating on the weekend. I don't.
I don't.
Dr. Arora?
Yeah.
You have raised your hand. You wanted to make a comment?
No, I raised my hand earlier, but yes, I have a comment. This is to the entire group. Hemant raised a point, and all of us feel that whenever we have patients where we stop the steroids, the inflammation comes back. Has anybody been using intravitreal lavage with betadine, povidone iodine?
In the end of patients, yes.
In the end of patient where everything else has failed, where you have a 0.0025% povidone iodine, which works extreme, but whatever the literature says, it works pretty well. What is the group's what do people feel about it?
As I mentioned, we have used it.
I've just used it once. Sorry, sir. Please go ahead.
Yeah, sorry. We have used it in patients who are resistant or recurrent disease. We have lavaged intraoperatively with povidone iodine and found it to work, of course, but not routinely, but only in end of patients.
Yeah. Okay.
All right. Aditya, you wanted to say something?